เริ่มแล้วนะครับเริ่มแล้วนะครับ
Walk through life. Every day is a new beginning. Shine your light. It's a day and the world is waiting. Move along to the song, singing in your soul. Feel the beat, clap your hands, let's take control. All you need, all you want, are you ready to find your way? 'Cause every day is a new day. And everything's going your way. And you wanna make it last forever. We'll keep it together, 'cause it keeps getting better. Walk through life. Every day is a new beginning.
วิดีโออีก1 นาทีครับจบแต่ไปครับ
And everything's going your way. And you wanna make it last forever. Well, every day is a new day. And everything's going your way. And you wanna make it last forever. Just keep it together, 'cause it keeps getting better. Hey, it keeps getting better.
Hi, good afternoon, everyone. It's my great pleasure to welcome all of you to the Songkla Nakarin Hospital, Prince of Songkla University. On my right-hand side is the chief of our cardiac center. Our official name is Narathiwat Ratchanakarin Cardiac Center. And first, I would like to have a few minutes to introduce our place. Yeah. We are the one and the only university hospital for the neonatal and adult cardiovascular disease in the southern part of Thailand. We stay near the border of Malaysia, so you're gonna take 1 hour flight from Bangkok. And we take care of the 14 provinces in the southern part of Thailand. We now have 4 CVT surgeons and 6 adult cardiologists and 4 pediatric cardiologists and 1 pediatric cardiology fellow and 1 fellow intervention. Yes. And I would say that today is very great honor for PSU team to be a host for conduct this meeting. And with the great support from my beloved mentor, Ajahn Borakan and Ajahn Pontep as a moderator. Yes, and now here we also have the great support from the great mentor from the Italy, Dr. Mario, and also from Vietnam, Dr. Tin, from Japan, Dr. Hideshi, and Malaysia, Dr. Go. Yes, and also in here we have the friends and colleagues from every part of Thailand as our team. So I'm sure that this meeting will be a very good start for a new frontier for the Asian community because we share the same problems and similar resources. And as I learned from the workshop from all of your knowledge, so I think it's an honor for us very much that our place is be the hub of the knowledge and the hub that we can share all of the idea together with my beloved friend that we want to see everyone in a person, but we cannot do it right now. Right? So I would like to say that thank you very much. Also, thank you very much for the support from the Life Tech and the Biopharm that we can make this webinar together. And yes, I will give the hand over to the moderator to start this meeting. Please, thank you.
Thank you. Thank you, Super. สวัสดีครับ สวัสดีครับอาจารย์เทียบครับ Yeah, so again, our honor and definitely pleasure to be here with lovely team from PSU, Songkla University Hospital. So let me start with the introduction of the program. If you can have a look that we are now having the program of the case demonstration and also the lectures. I think I'm afraid that maybe in the CAT lab is not really ready. Are you ready now?
I'm ready.
Oh, okay. Then let's move to the CAT lab first. If you can hear CC's voice, so CC, she is now in the CAT lab working to the team. CC, if you can introduce the people there, and then let's start from the case.
Okay, so welcome everyone to PSU CAT Lab. So today I'm with Dr. Kanjarat. So I will let Dr. Kanjarat introduce the team.
Okay, thank you, Dr. Cici. I would like to introduce my team. In right-hand side, Dr. Cici from the Queen Silicate. Yeah, everyone know her, yeah. And we have adult congenital heart disease, Dr. Thanawat. And left-hand side, Dr. Vacharapon, she is a pediatric intervention. And today we also have the Dr. Nakalin and Dr. Kaiwat for the echo man. And we have the anesthetic team, Dr. Jutharat. Yeah. And in there we have the nurse team from PSU together.
Okay, so we'll move to Dr. Elena, our fellow from Maldives, to present the case. Elena, please.
Thank you, Ajahn Sisi. Very good afternoon from Thailand again. I'm Elena. I'm from the Maldives. I'm doing interventional cardiology, pediatric cardiology here, and I'll be presenting the first case today that they have in the cath lab right now. So we have here a 5-year-old girl who weighs 15.8 kilos with a height of 108 centimeters. She has normal vitals with a pulse of 96 per minute. Her blood pressure is 100 by 60 millimeter of mercury. She has a saturation of 99%. She was diagnosed with a VSD actually since birth because of the incidental finding of a heart murmur at birth. At present, she has a grade 3 pansystolic murmur in her lower left peristernal border, and she is on low dose furosemide at present. We can see that she has a CT ratio of 0.5, but there is obvious left heart enlargement. We can see left atrial enlargement with increased pulmonary vasculature even in the chest X-ray. Her EKG is normal. She has a normal sinus rhythm and with a heart rate of 98 per minute. She doesn't have any arrhythmias. And here is the echo that we did last week. And then here we can notice that she has left heart enlargement, left atrial and left ventricular enlargement. She has a trivial TR, and the TRPG here was 20 millimeter of mercury. And we can notice that she has an VSD, which is of the aneurysmal type. And the jet is, we can see only one jet from the echo, which is directed to the RV. The measurements from the four-chamber view and the peristernal long axis, it is similar. So the LV entry measures around 4 to 5 millimeters. The RV exit around 3.5 millimeters. And the length of the VSD is 7 millimeters. We can see that there is some distance away from the aortic valve. But when we look at the modified short axis view, again, we can see the VSD jet directed to the RV only. And then the aneurysm, we can see it very nicely. And from this view, when we move to the tricuspid valve, we can see that it's near the tricuspid valve leaflet. So with that, we'll again move back and then see the live TE.
Thank you, Dr. Elena. In CAT lab, we have Dr. Nakarin to show the TEE. Dr. Nakarin, please.
Okay, let's see to the echo. With the Focean bell view, you can see my left ventricular enlargement, and we can see the VSD just beneath to the tricuspid valve, but just have the trivial TR. And also have trivial MR too. The VSD look like the tubular shape. We can see the VSD left direction. The size of VSD, the LV orifice around 4 millimeters and right RV exit around 3 millimeters, and the length of the VSD around 6 millimeters. The VSD just far away from the aortic valve. It's around 8 millimeters. And in parasternal long exit view, we can measure the VSD as same as to the previous one. The LV orifice is 3.5, RV 3.3 millimeters. And the length around 7 to 8 millimeters. Just to the RV exit, we can see a little bit of septal VSD aneurysm. And no AR. The figure of the VSD at tubular shape. So the final size of the TE is the LV orifice around 4, RV around 3, and the length around 7 to 8. And we just concerned to the tricuspid valve because of the VSD just beneath the aortic, the tricuspid valve. But the aortic valve is okay.
Okay. So according to the transesophageal echo, any comments or any questions from the audience or moderator?
Thanks, Cici. So let's start with from European expert Mario. You see the echo. So first question to me: is it feasible for the MFO? And if yes, what is your suggestion, please?
Yes, I saw the pictures, and it's very consistent with small to medium-sized VSD with aneurysmal tissue. And I think it's quite suitable for closure with MFO device. We have to decide the size of the device to be used and the route to be used. And of course, you can decide to use the conventional, let's say, antegrade approach or the retrograde approach. I think in this particular case, because the patient is big enough, 15 kilo, you can probably, personally, I would probably adopt the retrograde transaortic implantation of the device. And my preference will be to implant the device inside the so-called aneurysm. Yeah. This is very protective against, for example, AV block. So I think it's very suitable for device closure with MFO.
Thank you, sir. Tin and GT, please. Would love to hear your voice and your comments too.
Hi, Warakan. Hi, everybody. I just worried about the inlet attention. The defect looks inlet attention. And the tissue aneurysm tissue, I'm not sure it's strong enough, but TR is not so severe. I think it's enough. And if I use the MFO, please don't use oversize because the device will, the right side of the device will touch and catch the tricuspid valve, and we can create the new onset TR. Yeah.
Thank you. GT, please. Go.
Sorry, just now I was. Can you hear me clearly?
Yeah, it's very clear. Thank you.
Yeah, I'm still fumbling with the internet connection. I'm sure Hopefully I can see, but I'm still very blurry here. I'm not sure it's the internet connection or maybe the setting is not properly handled. So overall, I still think that this is suitable for device closure, but somehow I missed the diameter and the measurement just now. But I think it's a kind of small to moderate size. Uh, I think can be closed with the MFO, and maybe an angiogram will give me a better idea in terms of the sizing. Yeah.
Thank you. Hideshi, any words about this? I'm pretty sure that VSD is now emerging a procedure in Japan, but please, if you can share your idea.
We have our very limited experience of the MFO. I have only used the A6 MFO for the 3 or 4 millimeter VSD at this moment. But maybe for this particular patient, maybe smaller one may be better. For the defect, it looks slightly smaller than 3 millimeter or something. So, but my concern is again to tricuspid valve.
Thank you. So before we move to the cat lab, maybe if any last few words from Ajahn Pontep, if you can share your idea, please.
I agree with everyone about the RV size of the VSD tunnel, and as Dr. Tin mentioned about not oversized, and others also mentioned it. I think let we have some more information from the cat lab, especially angiogram, and we will discuss on the size of the device.
Okay, thank you. Thank you. Cici, so Anja, you hear very wisdom words from all the experts around the globe. So
Yes.
now, please, the choice is yours. Please let us know what you are planning to do and what is any other or further information you may have.
Yeah, so LV angiogram has been done. So Dr. Thanawat will show you the picture. Can you see the AP lateral picture from the catalog?
Yeah, you can see
Yeah.
it.
Okay. From angiogram data, you can see the perimembranous VSD looks like the turnout similar to echo data. For the LV entry size, the measurement around 4 millimeters and 3 millimeter for RV exit point, 7 millimeter for length. It looks like or similar to echo data. And for hemodynamic data, we already complete left like hard cut, show normal artery, pulmonary artery pressure, QP, QS ratio 1.4, and pulmonary vascular resistance 0.8. That is hemodynamic data already done.
Okay. So from the AP view, in my opinion, I'm not sure there is all, one exit, RV exit, or more than one RV exit. Any comments from the audience? The upper one is only the blind pouch one, or do you think it's more than one exit on the AP LV angiogram?
So Tin, if you can help us on this.
Yes, may I make a comment?
Yeah, please, Mario, please.
Well, in the lateral view, we see a picture suggesting some kind of aneurysm.
Yes.
However, the hole is below this aneurysm, actually,
Yes.
in my opinion. So, well, the aneurysm as the VSD in the LAO is a bit, well, not clearly seen. You better seen in the lateral view. And
Yeah.
be as yeah.
So, Mario, when you see these angios, is there anything in your mind that changing, or will you just planning the same retrograde approach and then doing putting the MFO?
Yes. I think so. It's a small VSD. I think there is a far distance from the aortic valve, so I think it's going to be possible to enter the VSD from retrograde approach, maybe with cut pigtail or right Judkins or something like this, and certainly implant the device there. a small device that I think will be enough to close this hole. I mean, theoretically, an advantage to use the retrograde approach in such anatomy is to be probably safer as far as the tricuspid valve, because you can open the distal disc in the right ventricle, and with transesophageal echo, you can be quite sure you are not interfering with the tricuspid leaflets. That's my impression for this case.
Thanks, Mario.
I
Yeah,
have
please.
one question, Mario. By the lateral view, you can see the RV orifice, the direction of flow point toward to the right ventricular outflow tract. Is
Yes.
necessary to pass the guide wire to this tract and retrograde approach, close the deploy the device at this tunnel, or the guide wire can be to the other orifice, because the guide wire enter to RV in the RVOT orifice, and the RVD should be deployed at that position, it will far away from the tricuspid valve. Or you have any other idea?
Yeah, I mean, some consideration have to be proven practically. Well, the great advantage of this device is that you can screw it or implant from both ways. So I think you can choose antegrade or retrograde way and see what's going on. If you're not happy, you're always in time to change and do the opposite. With such anatomy, when I'm not sure, my preference sometimes is to use a safety wire on the system, I mean a coronary wire on the circuit, in order to be able to change your idea without losing the access to the VSD. So you can start from retrograde or antegrade. If you're not happy, you can do the opposite.
Mario, can I make a comment? If
Yes,
you are not
sure.
sure whether there's a small exit or another additional exit, is it probably better to go antegradely, and then you can do a better angio, and if you need to cross again, it's much easier that way, rather than doing a retrograde?
Yeah, I mean, if you're not sure about the anatomy, you can do additional angiogram. Yes, sometimes I agree with you that sometimes if you're not happy or sure about the anatomy, repeating an angiogram with a sheet inside the VSD can clarify the anatomy a bit better. That's a good observation for sure.
So there's a question actually from Robin Chen from Hong Kong. So he spotted that probably because from lateral view, it looks as if there's another pouch above the VSD jet. Not sure whether if there's any, this is a complex septal aneurysm or not. So maybe the question from Robin would be, are you guys happy with this angio? Do you want to do anything more than this or not? Or should we do things like Dr. Ko mentioned that we should put the sheath in and then we do angio again? So Tin, if you can share your idea, please.
Hi everybody. We can see clearly the check from the lateral view, but we could not see clearly from the. I think you are using the 30-30, and so I think the shunt from posterior to anterior, but with the lateral view we cannot see the ampulla clearly about the ampulla. Maybe it's a one entrance. But to assist, one assist through the RVOT, but one assist is almost punch. And I think if we can do more angiography, maybe we change to the angulation 60 and 20, 60 LAO and 20 cranial, we can see more clearly. Or I think the best option is the advance the sheath and do angio after the sheath crossing.
Thank you. So, any other comments from the panelists, please? Otherwise, Cici, you get
Yes.
the comments which is variable. Please,
Yes.
what's your plan? What do you think?
So first, I'm agree with doing retrograde approach in order to check that there is the TR after implantation or not, because the defect is very close to the tricuspid valve. So then we can do simultaneously transesophageal echo to check when we open the RV disc that we cause the TR or not. And then because of we are not sure about the anatomy, what we did right now is we have another arterial puncture just to put another pigtail while we are putting the device in, just to recheck that another one which is above the one that we saw from the retral view is the blind pouch or is another hole. Because of the size of the device that we going to select, even though it's small, but the disc is larger than the pouch in the LV anyway. So I don't think I'm gonna do the integrate approach uh, because of the just because of the anatomy.
Okay, thank you. Thank you. So where are you now, by the way? Then?
So we already closed the defect. Dr. Vacharapon closed the defect with using JR and Terumo guideline. Can you see the picture here, right? Okay. So and now we place the wire in the LPA, and we about to cross it with the long sheet. So before we select the size of the long sheet, so any idea about the size of the defect?
So you asked about the size, right?
Yes,
Yes.
because
So-
we wanna know that the long sheet that we're gonna put in
Okay.
is enough or not.
So presumably you're gonna put the MFO in. Am I correct?
Yes.
Yeah. If you can show us for those who not get used to the device, if how many sizes that the MFO has.
Yeah, can you
please.
show the slide from
And then,
okay?
okay, all right. So looks as if for the MFO, we have the smallest one, 3 millimeter, right, at the
Yes.
waist, and the largest one is 12 millimeter.
Yes.
So remind us again the size of the VSD. This particular case, what is the waist?
The RV exits about 3.3 to 3.5 millimeters.
Okay, so about 3.5 maximum. So maybe all the attendees, please, if you can put some ideas into the chat box, we can you can hear from you guys too. But in the meantime, please maybe start with Hideshi. Please suggest us what size that we should use for this VSD.
It's very tough question for me.
Okay.
Maybe 3-4.
3-4. Okay, thank you.
3-4.
Ajahn Pantep, what do you think about this? 3-5, right?
3-5.
3-5.
Oh, 6-4.
6-4. Okay, 6-4. 6 means D2 is 6 and 4 is the waist. Okay, thank you, Hideshi. Ajahn Pantep, what do you think on this?
For me, I think both 3-5 and 4-6 is possible, but I choose on the side of 3-5 because I think I did not want I don't want the RV this
Yeah.
to
So you prefer the smaller one?
yeah.
Yes. Maybe Cole, please. And then Mario and maybe Chen, please.
Sorry, I just now I troubleshoot a bit, but I think MFO is a device that is a lot of flexibility. The sizing, I think we can accommodate either the one that you all mentioned earlier, or I would do it 6-4. I think it's okay. I think it's a very soft device, and you have a lot of room to play with. Sometimes you upsize one step or lower one, I think it's not going to matter that much. Yeah.
Lovely, thank you.
So actually,
Sorry,
the
Supa,
both sides.
sorry, Supa, sorry, Cici. Let's add some Mario and Tin, and then we follow your idea, please. Mario, please.
Yeah. Yeah, I will probably use a 6 French introducer and then repeat the angiogram and decide what size of device to use. Most likely the 6-4 device.
Thank you, sir. Thank you, sir. Thank you, sir. Can you hear me?
In?
Okay, thank you. Tin, please.
Yeah, I think 6-4 is okay because the 3-5 or 6-4 is same retention distance 10 mm, and why not 6-4? And my experience, I don't use the long sheath. I just use the guiding catheter 5 French, and we can use the 5 French guiding catheter, and it's very easy compared with the long sheath.
Lovely,
Yeah.
thank you. Cici, please.
So we agree with all comments actually because I think both side is actually suitable for this case, but because the right side is of the both side are similar as Dr. Tin said, which is 10 millimeter. So I think it's safer to go for the bigger one. So we select the 6-4 device for this case. So then Dr. Kancharat will show you the device that already open on the table.
Okay. Yes, in our team, select the 6-5 in this patient.
Can you zoom in?
Can you
her
see
Kancharat, you
it?
mean
screen?
6-4, right?
Yeah.
Yes.
Okay.
Yes. Okay. From here, you can see the device either both this in this one is the LV this.
Can you zoom bigger than
Can you
this, please?
zoom?
And don't, be careful. You may,
Okay.
you may drop the device. It's very
You can see here.
a small and sleek one.
Zoom more. Okay. Atan Walakan, can you see clearly?
Yeah, it looks very clear now. Thank you.
Okay. This one we call the LV disc and RV disc. In this patient, we select the 6-4. 6 is stand for here, and 4 stand for here, and both this is equal 10 millimeter. Yeah. In this side, we put in the LV in the high pressure, and this side we put in the RV in the low pressure. And this patient we decide to the we decide use the retrograde technique. When we loading the device, I connect the disc cable in this side. The cable connect in the LV like this for the high pressure. Can you see here? Okay.
Yeah.
I will show you to loading. We use the screw-in technique. In this device can loading in both sides. Okay. It smoothly screw in. And we will check the click again to confirm the connection. Yes. Click sound is well. Okay. And we will loading the device in the loader.
Later on.
Okay, I'm already done to prepare the device with cable. Now in cath lab room, perform pass the long sheet to the VSD to the RV.
Can you see the angiogram, right?
Yeah, we can see the fluoroscopy now.
Yes.
So just reminding us, what you have on the right ventricle is a guiding catheter, 6 French, am I correct?
Yes, it's the 5 French long sheet
okay.
from the
So
MFO.
5 French long sheets
Yes.
from the LifeTech.
Yes.
And so with this, will you do the LV angiogram?
Yes, we about to put the pigtail in and
Okay.
repeat the angiogram.
Okay. Okay. So generally, if you have the sheath in the aorta, then you can put the pigtail, I mean, to the LV to do angio without additional artery access. So in this case, as Sisi mentioned previously, that the patient size is okay, and we prefer retrograde. So that's why she puncture another femoral artery. But anyway,
Yes,
yeah.
because
Okay.
we
So
just want to make sure about the anatomy
yeah,
before putting the device in.
yeah.
So right now, Dr. Vacharapon and Dr. Thanawat about to put the pigtail in, and we about to show you another LV angiogram, and then we will discuss.
Go to the LV. Okay.
Okay. So angiogram, please. Angiogram, please. So, Dr. Warakan, do you think that we need to change the angulation before repeat the angiogram, or we will stick with this?
Well, according to Tin's suggestion, I think we should change a bit. But
Okay.
Tin, to be honest with you, I can't remember what is angulation recommended. Sorry for that. Please remind us again.
60 LAO and 20 cranial.
Okay, so 60 LAO CC and
60
cranial
LAO
20. 60
and okay.
LAO and 20 cranial.
Okay.
And lateral will be like that, right, Tin?
Can
Yeah,
you move
awesome.
the probe,
Okay.
TE probe, please? We will do more LAO. Wait. Okay.
But I think we need one magnify, make it bigger.
Pardon?
Yeah, Tin needs zoom.
Okay. We'll zoom for you.
Zero cranial, right?
20 cranial
And 20 cranial.
and 60 LAO. Can we go more? Yep. Okay. And then can we zoom in? Okay.
It's enough.
Can we zoom more?
60 cannot.
Okay. What maximum we can do? So I think should be
47.
enough. So we can go about 50, and then we about to zoom in and do LV angio. So can you follow by plane first? Okay. Can we maximize the picture more? Okay. Okay, follow by plane again.
Okay.
Okay, this is the maximum we can go for. And then angio.
Okay.
Yep.
Cine.
Yes.
Now. 2, 3.
Very close.
Yes, it is the one axis.
Interesting, huh?
Yeah.
That is the
So
bipouch.
it's like
So
a
Tin-
bipouch.
Tin, you request this angio with the sheath in. So what do you think?
Yeah, now we can see the one entrance, but two opening axis, but one opening axis on must be closed.
Yes.
Just on only one below.
So will you still confirming the 6-4 MFO?
Loading the device.
Yeah, I think 6 4 is safer and okay.
Yeah, please, the panelists, if you have any other opinions or we should change the device size, please let us know. Otherwise, Sisi, please continue.
Okay.
Put inside.
I have one question.
Yes.
Would
Yep.
you write place LV disc in the LV side of interventricular septum or inside the aneurysm in such a multilobulated cauliflower-like aneurysm?
Sisi, you get the question, right?
Yes, I will plan to put it inside the aneurysm.
Inside.
Yes.
Yeah.
So now we about to put the device in. So we'll pull pigtail back a little bit before, and then I will ask Dr. Nakarin to do the echo at the same time when we open the right disc.
Put out.
Yes, go slow when it close to the long sheet because it's maybe close to the RV wall. So we'll put the device close to the exit and then pull back to open the right side disc.
Move to the tip. Yep. More.
Okay,
Okay.
now the device is close to the tip, so we'll pull back the wrong sheet to open the right disc, and then we'll pull the whole system back.
Push cable.
Yeah.
Yep.
So can we go both?
Push
Okay.
cable. Push. Yes. Yes, we can see
Okay.
the fully RV disc.
Yes,
Yep.
and then we will pull back the whole system until it close to the tricuspid valve, and then check with the echo.
Yeah. Yeah.
Yes.
Yes.
Now the RV disc is touched the tricuspid valve and we have no TR. So then Dr. Washirapon will open the rest of the device. Push.
Push cable more.
Push the cable. Push the cable.
Push.
Yeah, push more. More. Yeah, can we push more?
Push more.
Okay.
Okay.
So this look nice. So can you check the tricuspid valve, Dr. Nakarin? Any TR?
No more TR. It's look good.
Yeah, any shunt left?
It's okay. Just my central leak. A
Oh,
little
somebody is doing bubble test, huh?
bit. Bubble test, right?
Go to
Then
the
CC, can you hear me?
Yes, I can hear you.
There is this new onset AR or
out.
baseline was there?
Oh, okay.
Can you repeat the questions again for me?
Maybe the question from I'm not sure. Naresh, about the new onset of aortic regurgitation. So what do you think on that? Because
Okay.
we somehow see the leak, I mean the aortic valve leak.
Okay, but we still have the cable which is across the aortic valve. So I will try to move the cable. I will let Dr. Kanjara try to move the cable while we do the live TEE and let's check if any change of the aortic valve regurgitation or not. Can you push the cable
Yeah,
now?
but now we have two catheter. I mean,
Yes.
one catheter
Yeah,
and
put
one
the
wire, right? I
pigtail.
mean, the cable.
Oh yeah, now
Yeah.
now catheter together
Yeah, the
with
pigtail
the
and
yes.
also the cable.
So let's do the LV angiogram and then remove the pigtail out and then let's see how it look again. Because we are about to do the angiogram right now. Wait a bit.
So can we zoom more, or that's the best we can get?
I think this is the best we can
Oh,
get.
okay, all right, thank you.
So angiogram, okay.
Okay.
We'll go cine.
Okay. I'm ready. I'm ready to see.
Yeah.
I think complete
I
now.
think
So
it's
wait, Cici.
yes.
Let's ask Mario first. What do you think, Mario?
So we
Is
remove
it
the
okay?
pigtail off and then look at the echo.
Well, yes, I think I'm happy about the device position. Probably the tiny aortic regurgitation is due to the tension of the delivery system, which is still attached to the device.
Just pull back.
I
We'll do
will not
angiogram
be
again.
very concerned about the
Just pull
aortic regurg, but it's worthwhile looking at aortic leaflets with echo. If they are moving well, I'm confident that there is no issue of aortic regurgitation, actually. Because you see there is a tension there due to the delivery cable.
Okay.
But it's probably worthwhile doing an aortogram as well, if you don't mind.
Okay, so
Now you see more of the
still have
regurgitation.
trivial
Thanks,
AR.
Mario.
I
So in your practice, Mario, will you do the angio by the picture and another picture, or will you do the angio through the sheath? If you go for retrograde approach.
Well, I use usually another peak day, like CT is doing like this. Yes.
Yeah, thank you.
So normally I do only one atrial puncture if we are sure that we sure with the anatomy, and we will do just the check angiogram to the sheet, and then we will strict on the echo. But in this kind of case, we will do two atrial puncture like this. But normally
Yes.
we'll do
But
only one puncture.
yeah, the drawback of retrograde approach is that when you have a delivery cable through the aortic leaflet,
Yes.
it's rather difficult to predict 100% what's going on when you release it. That's the small disadvantage of a retrograde approach.
Yeah.
Yeah.
But
So
it's in this case, I don't think it's the left disc is touch the aortic cusp, because from the angiogram is total of the left side disc is in the pouch. So I think
Yes.
this one could cause from the cable, and then we open the device from the right side, so it's unlikely to injury the aortic valve. So I still thinking that our leakage here is causing from the tension of the cable only.
อาจารย์พรเทพครับ should we release it? Any concern here
Yes.
or anything that we should aware?
I agree with CC. I think we better unscrew the cable and let's see about the aortic valve. I agree with Mario also that I think the device did not interfere with the aortic valve closure.
Thank you. So from the opinion from the audience also are very happy for the position of the device. So they said couldn't be better. I mean in terms of the positioning. So looks as if everyone is happy, and looks as if we are encouraging you, Sisi, and the team to release this device.
Yeah, already released and then show you no AR. As you see our echo right now, AR disappear.
Right.
Yeah.
Oh, you did release already.
Yeah.
It's
Lovely.
released already.
So quick.
I'm still teenager, cannot wait too long.
So, Cole, what do you think? Position-wise, is it okay? You happy? Maybe he's in the cat lab with Tamim and he's not ready. Tin, any comments on this?
Sorry. Yeah.
Sorry,
I think
Cole,
it's
please.
perfect. Yeah. I'm very happy with the device placement and overall. Yeah, I'm very happy. Yeah. Sorry, I'm still struggling with my connection.
Sorry. Okay. So, Tin, any other comments?
Yeah, I think I'm happy. Just one thing I don't happy with the CC. I don't pull back the pigtail. I keep the pigtail, release the device faster.
Okay.
That's a perfect result. Perfect
Yes.
result.
Yes.
So actually I pull back the pigtail because we need to check for the AR. That's why I just try
Yeah,
to
no need
check.
to check. No need to check.
So we will do the last angiogram after we release the device, and then we'll see that
Okay.
how the
So in the
device
meantime, while you're preparing the angio, if Nakarin, if you have any comments from the echo,
Oh, it's
anything in particular?
so beautiful.
Oh, okay.
It's okay.
It's a great comments actually.
All right, Dizzy, so we are waiting for your last shot of angio.
Yeah.
Okay.
Okay, we are ready.
Okay. Yeah.
Big round of applause to the team.
Right.
So maybe a question to Alina sitting beside me. So should we do aortogram? Should we do aortogram in this particular case, or just leave it like that? Do you concern on the aortic valve problems?
So in the final angiogram,
In this,
you mean?
yeah.
The final angiogram, it looks so perfect. I was actually going to ask whether do we need the angiogram, because in the echo, we can see it very nicely sitting. There was no AR and almost no TR. So actually that was the question I myself was thinking.
Yeah.
Can we not, like, do we need it or not? So maybe we can skip it.
Yeah, so the reason I'm asking because you know some of the centers around the world they do this procedure without fluoroscopy, so they don't really need angio at all. So
Okay.
that's why I'm asking your opinion whether should we do angio in the aorta or in the left ventricle. So looks very nice. So any comments or question about the procedure, please let us know. Maybe the panelists or others. Mario,
I
any?
think that's
Yeah, please.
well, that's a perfect. I think that's a perfect result. I agree 100% of the way to conduct the case, the choice of the route from retrograde approach, the size of the device, and the great results. Congratulations.
Thank you, sir. Okay, so Cici, anything you want to say more?
I just want to say thank you, and I think it's not done by me, so my hand's still very clear, no blood stain on my glove because it's all done by our younger colleagues. So, congratulations to all of them, and thank you for allowing me to have very great opportunity to join the meeting. So.
Thank you, Cici and Kantarat and all the teams there. Congratulations. Yeah, so if the audience have any question, please put it in the chat box. I think we don't have the Q&A. Oh, we do have Q&A. And any place I think is fine. That's a question from Jun Sato. Cici, just a question there. Jun asked if we saw moderate TR after deployment in this case, what should we do?
So first we will try to retrieve the device and then try to manipulate that. This is late because of we attach to any leaflet of the tricuspid valve while we're pulling the device back or not. But if the TR still proceed because of the right disc of the device, MFO device, the smallest size, and this size will be similar, which is 10 millimeter. I would select the device which is have low profile on the right side to reduce the problem of the tricuspid valve regurgitation.
Thank you. Any other comments from the panelists? Thank you. So once again, thanks for the great demonstration of the case. So let's go back to you in the CAT lab later. But in the meantime, so let's start with some lectures. Maybe before I